All right, so thank you so much. Once again, I'm Chris Mathis from Kansas City, and it definitely is an honor to be here and presenting to you all and kind of be in the midst of all the great brain power, as well as being here with the families and hearing the patient side of the discussion. So we'll obviously, as mentioned, we'll be talking about HRC3 partner centers and development of a clinical toolkit. We have no relevant disclosures. And so just kind of starting out, we've heard about a lot of innovation, especially from the last session, about kind of advances and kind of the multidisciplinary approach to heterotaxy. But the typical approach or past approach and the status quo in many centers across the country really is that of kind of siloed care and kind of independent management amongst the subspecialists involved in these complex patients. The management historically has really been driven kind of out of necessity of the rarity of patients with heterotaxy and the paucity of research is that the management has really been driven by the approach in non-heterotaxy patients. I think one pertinent example is that of the use of a prophylactic LADS procedure in patients with asymptomatic malrotation, which historically was kind of a common push and recommendation. Fortunately, over the past decade or so, kind of additional information has really changed that recommendation for more conservative management, as we heard yesterday. As was mentioned earlier as well, regarding kind of the existing research landscape, a lot of the recommendations in the majority of studies really are largely single center based experiences and studies, kind of reporting outcomes, which can have its challenges. And again, as we've mentioned, there's many knowledge gaps that exist. And so as part of the HRC3 committee, the hope is that we can change this current the status quo in heterotaxy care. One of the hopes to be able to kind of move that along is to encourage and kind of increase the accessibility to multidisciplinary care for heterotaxy patients across the country. Using some of the models of that we heard about in the last session at UT Southwestern and in Boston, really to kind of bring that programmatic approach kind of across the country for easier access for our patients. Kind of along with that is trying to improve the standardization of care across centers, which I know for families and hearing about some of the experiences can be incredibly frustrating, and obviously taking families out of their support, kind of their local centers of support, and having to travel across the country to receive expert heterotaxy care can be an additional strain on families. And then ideally developing or coming up with unique ways to leverage a national registry to help encourage and expand future research. So one of the first steps to kind of achieving some of these goals was to develop the HRC3 clinical toolkit. This essentially is a compilation of general recommendations for the diagnosis and management, which is really based on kind of currently available data as well as expert opinion as well. The intent of this is to be kind of a live or a living document that's routinely reviewed and can be easily updated in a timely manner to reflect any new information. Some of the additional information included in the toolkit includes recommendations for personnel and resources that would be necessary and important for developing a high quality heterotaxy care center. In addition, we had the recent 2022 paper on the comprehensive approach to the management of children with heterotaxy. And this toolkit kind of takes a step beyond that to also kind of address some specific subsets of patients and potential clinical scenarios that may not have been as addressed. I know Dr. Shapiro yesterday had inquired and asked about center experience on patients with PCD and their ability or their candidacy for single ventricle palliation and Fontan palliation. And that's kind of a specific one that we address within the cardiology section, just that that isn't an absolute contraindication, but more kind of dependent on specific anatomic factors and their hemodynamic data. This is just kind of a screenshot of the various sections of the HRC3 clinical toolkit and the authors that are involved in the current iteration of the toolkit, which will obviously be an ongoing work going forward. Many of the authors on this list have been present and involved here this weekend, and so thank you to everyone involved in making this happen and making this a reality.